There we go. Well, hi, and welcome back to another weekly Lunch and Learn. I'm Dr. Kara Pepper. I'm glad you're here listening to this either live or on the replay. For the past couple of weeks, we've been talking about mast cell disease, what it is, how to treat it, and things that you should know. And today I want to talk about the heart and soul of my practice, which is this overlapping syndrome of mast cell activation syndrome and eating disorders, and why we tend to see so many folks who struggle with eating disorder behavior have this overlapping constellation of co-occurring conditions. I am an internist in Atlanta, Georgia. I see people in person and also via telemedicine in multiple states. And the way I got into this work was really through eating disorder care, but my practice has evolved into this invisible disease, so to speak, constellation of symptoms with POTS, mast cell disease, Ehlers-Danlos, and then menopause care, and a lot of just regular primary care. A reminder that I am a doctor, not necessarily your doctor. Please do not take this as medical advice for you as an individual and discuss it with your clinical team. The greatest teachers I've ever had are my patients. Yes, I went to med school. Yes, I went to residency, and I've met brilliant people all over the world, but medicine is really an art. We learn about the technical aspects in our training, but it is really the application of that with real life humans that creates our practice style. And we certainly did not learn everything there is to know in medical school. Anyone who's a patient in our healthcare system knows that. But the things that I continue to learn as my career continues to evolve is really directly from the people I take care of. And I think this is a great example of all of that. So as I got into the eating disorder world, not that I would wish an eating disorder on anyone, it is a huge life encompassing problem, but no one, heavy use of air quotes, just had an eating disorder. I found that people that I was taking care of really had a number of other co-occurring conditions that were also either one, not diagnosed, or two, poorly understood. And these are a lot of abbreviations for things like Ehlers-Danlos syndrome, postural orthostatic tachycardia syndrome, mast cell activation syndrome, which we'll talk about, median arcuate ligament syndrome and SMA, which are vascular problems in the belly, mood disorders, infections, dysmotility, autoimmunity, dysautonomia, and ME/CFS, chronic fatigue syndrome. So it's a long way of saying that people had a lot of things that they had seen doctors for, that they'd had scopes, scans, labs, everything was reportedly normal, but they just simply did not feel well. And I realized very quickly that I could never really get people past their eating disorder until we addressed the other things that were in the room. This is an incomplete list, of course. And what became clear to me over time was that it really wasn't the eating disorder that was causing all of those other issues. There's many, many reasons why people develop those symptoms, but at the center of that really was this underlying inflammation, and trying to figure out what was driving the mast cell activation syndrome really made a difference in eating disorder care. And more specifically, until we addressed all of these things, nothing ever really seemed to get better. People would stay in the spin cycle. So for example, if I didn't really address their food sensitivities, eating was going to be a real problem. Or if I didn't address dysmotility, the feeling of bloating or heaviness in your belly would always inhibit people's desire to eat. Or until I really addressed the chronic fatigue that was keeping people apathetic and, just unable to really engage in treatment, they would never get better. So all of these things are connected. And until we address them comprehensively, people really are suffering. So because patients are our teachers, I want to give you 3 examples of a typical type of patient that I would see in clinic, and how these things tangibly overlap. So this is a 24-year-old non-binary person who carries a diagnosis of anorexia nervosa restrictive subtype. And they were diagnosed in their late teen years with a number of chronic conditions, several of which I mentioned earlier. So they had an autoimmune disease, which showed up in the form of lupus. They have autonomic nervous system disease, which showed up as gastroparesis. Their stomach wasn't emptying well. Their blood pressure would drop and their heart rate would go up. They had POTS, postural orthostatic tachycardia syndrome. And then they also had some connective tissue disorder in the background. They were hypermobile and got diagnosed with EDS. And so they've been kind of trucking along in the context of having their eating disorder and these other co-occurring conditions. And then they experienced a trauma, an assault, that in the aftermath of that, a lot of their chronic symptoms seemed to get worse. Their GI symptoms got worse. They were more constipated. They had more belly pain. They had more nausea. And they also developed more joint pain. Like everything seemed to hurt. Their skin hurt. It hurt to move around. And when they saw their typical team, their doctors would say, yeah, of course, this is your lupus. Yeah, of course, this is your gastroparesis. You're just stressed. Stress shows up in these ways. It's impacting your immune system and your GI tract. And so let's just focus on the diagnoses that you have. So that's one. The second would be a 48-year-old trans woman with a long history of this so-called OSFED, which is kind of the catch-all eating disorder criteria, DSM-5 criteria um, that doesn't really fully meet criteria for anorexia nervosa binge purge subtype, but that's the diagnosis that we have. They'd been in and out of treatment. She'd been in and out of treatment for many, many years. And she'd gotten fully weight restored, but she still continued to have a lot of belly pain, a lot of bloating, a lot of nausea. And everyone kept telling her, if you just, stay in recovery, just give it another 6 months, your belly symptoms should get better. And then, the pandemic came around, she got COVID, and then developed this long COVID scenario where she had brain fog, fatigue, really struggled with this, what we call post-exertional malaise, where anything that she did would render her exhausted. So she could either go to the grocery store or cook dinner, but couldn't do both in the same day. She developed some skin rashes that were particularly sun sensitive, and never really seemed to get better. And kept saying, like, and came to see me, why are my guts not getting better? And then the third example would be like an 18-year-old cis male who carried a diagnosis of ARFID, had been labeled as a, quote, picky eater as a child. But when you really get into it with him, he would say, I just never really liked eating strawberries or tomatoes. When I ate them, my tongue would tingle, I would feel kind of itchy all over, and it would make my stomach hurt. And I didn't like eating them, but I grew up in a family that has the Clean Plate Club. And so people would make me stay at the table for a long time. By the time he was 8, he had an episode of anaphylaxis that did not have like positive food testing and allergy testing, and so really started to develop some fears around food. Really was nervous that he was going to have another episode, and so started to restrict food more. And then as he grew into his teen years, started to develop some rashes, particularly in the warmer months of the year, and especially when he was in the shower. Heat seemed to be a big trigger for him. So if we look at these 3 cases of patients, they all kind of have different stories, different diagnoses, but there's some similarities that I would start to see in the pattern of patients that I was taking care of. And a lot of that can be drilled down to mast cell disease. For the past 2 weeks, you can go back and take a look at my talks on mast cells, but in effect, the mast cell is a type of white blood cell that releases these granules. These purple blobs are full of chemical mediators, including histamine. And when histamine and other mediators hit your bloodstream, they can cause symptoms literally from head to toe. And so some of the clues that I'm looking for when I listen to patients who come in are, one, they tell me, I've seen 10 different doctors. Everyone tells me I'm fine. I've been scope scanned, head labs, and everyone says that I'm fine. So symptoms that are not explained by structural data or routine labs. Symptoms that start after a big event, either a trauma, an illness, or an infection. So COVID is like the thing that we're seeing a ton of, and people develop symptoms in the aftermath of that. Symptoms that pre or post date their eating disorder behaviors. So for like the young man who had these food sensitivities, he had that well before he developed the fear around food and the restriction of food. He clearly had something that was going on there. And then in the 2 previous cases, those folks had gotten into recovery, but still continue to have symptoms, for example. Often the patients will weight restore or be in recovery for years, but still continue to have these chronic symptoms that linger and no one has a great explanation for. And then just that overlapping picture that I showed with all the squares in the beginning, they come in, they don't, quote, just have an eating disorder. They've got all this other stuff that's going on that tells me that there's probably an underlying cause. Anaphylaxis, of course, with true mast cell activation is a real thing. And so that's definitely a key indicator. And then some kind of curious things that patients often say, like, I'm really allergic to my period. Before I get my period, my mood gets so much worse. My symptoms get worse. My joint pains get worse. So estrogen-driven cycles tend to aggravate symptoms. I'm allergic to alcohol, both in topical things like creams or consuming alcohol, or VOCs in the environment. People will say, those will really exacerbate my symptoms. And then some things in the food supply itself, like I'm allergic to food dyes, or I think I'm allergic to gluten, but when I went to Italy, I did fine and I could eat pizza and pasta, no problem. So is there something in the foods that they're eating specifically? Those are some of the clues that I start to listen for. There is a world-renowned clinic out in Colorado with Dr. Jennifer Gaudiani, and her team has developed this screening questionnaire that's a first pass that anyone can kind of do the checklist and see if they meet criteria. It's 6 basic questions that any clinician can use. They call it the RASH PF screening tool. So you can see our first letters over here. So the R stands for reactions, like are you having physical reactions to foods, medicines, scents, or body products? The second is alcohol. When you drink alcohol or use alcohol-based products, do you get flushed, itchy, have abdominal pain, distress, worsen mood, joint pains? So is alcohol a trigger for you? The S is for skin. Do you often get rashes, hives, or itchy skin? H is for heat. Do you feel unwell, swollen, itchy, fatigued after spending time in the heat or sun or shower? So my whole practice feels like it's on fire right now in the heat of Atlanta. P is for pain. Do you experience chronic pain, especially joint, digestive, head, or muscles? And fatigue. Do you feel chronically or frequently unexpectedly fatigued? And so if you're doing this screen as you're listening, if at least three out of the 6 questions here are a yes, then that's our clue to be like, there's probably something going on and we should do a full MCAS screening survey. So why? Like the scientist to me is like, this is fine. Like, is it all just correlative? Like perhaps these things just happen to run in the same circles, but we don't know why. And the truth is we are still trying to gather that data. Unlike cardiovascular disease, like blockages in the arteries where there's billions of dollars of research and decades of clinical studies, we don't really have that in the mast cell activation world. And so there is some preliminary data and small cohort studies that have been published, and I personally am doing a research study right now to look at some of the incidence of these things. We're trying to get this data out so we have real numbers. But from what we know, there's a couple reasons why I think eating disorders and mast cells tend to show up in the same folks. So the first is that mast cells, when they get activated, release chemicals that also suppress appetite. So if you're already struggling with body cues, if you're already struggling with appetite, if you're already having some fears around foods, these chemical mediators can actually suppress your appetite further. So it can worsen restrictive patterns of eating. The second is that I mentioned that mast cells live head to toe. So there is some data around neuropsychiatric inflammation. And there was a small cohort study that looked at folks with so-called refractory depression. They tried all the traditional measures and really had never gotten past their significant disease. And when their mast cell disease was treated, they actually had improvement in their anxiety and depression symptoms. So is it because the mast cells themselves are inflaming the brain, so to speak, and causing some psychiatric symptoms? Another reason that I see commonly, like that young man with ARFID, is that some folks can have visceral or physical symptoms. So if you don't like the way you feel when you eat, you're bloated, you have belly pain, you have an allergic reaction, understandably, we would try to avoid some of those foods or behaviors that create those symptoms. So is it just the physical experience that mast cell activation is creating that inhibits our ability to eat food? And then gastroparesis, I mentioned the dysautonomia piece of things. That certainly can make it harder to empty your stomach or empty your colon. That makes it hard. And then lastly, is it truly food sensitivities? Even if the allergy testing is negative, if eating certain foods create these symptoms, understandably, that's going to create some avoidance of those food behaviors. So the short answer is, I don't really know exactly, but I think there's probably a number of reasons that we're starting to see the overlap in this. The very basic data that we have right now is that MCAS is seen in about 20% of folks with eating disorder behavior. I certainly have selection bias in my practice, but I would say quite easily half of the patients who I treat for eating disorder behaviors have some degree of mast cell activation syndrome. As a reminder, what is mast cell activation syndrome? Not only do those mast cells experience a trigger, and this is a non-IgE mediated response, so basically something in the environment or something that we consume activates the mast cells. They release all their little granules. And then before we know it, it looks like pollen season in Atlanta with tons of histamine everywhere, among other chemical mediators. So our treatments are, one, avoid the triggers, because there's no amount of medication that's ever going to overcome this. Two, stabilize the mast cells. And then lastly, block the histamine downstream. I talked a lot about triggers in last week's talk. You can go back and take a listen to that one, but I want to talk again specifically about food. One of the biggest questions that I get asked from patients is, okay, should I go on a low histamine diet? Anytime we restrict foods, our brains naturally start to crave those foods or think about those foods or plan for those foods more. We know this from starvation studies that have been done over the past century. And it certainly is a way where our brains subconsciously can kind of collude with the eating disorder. So my answer is, I believe you when you tell me that when you eat tomatoes, your mouth feels like it's on fire. If we're going to eliminate something, we need to add in something to replace the bulk nutrients there. So it's not an excuse to allow the eating disorder to go haywire and avoid eating entirely. It's a way to say, if this thing needs to be eliminated from your diet, either temporarily or long-term, we need to make sure that there's a way to get the nourishment that your body needs. Some of the common foods, and this is an incomplete list, that I hear from patients all the time. I mentioned tomatoes and strawberries, but some of the big ones are leftovers, when we can avoid eating leftovers, or batch cook, freeze the food and eat it defrosted one day at a time. That can make a big difference. There's no nutritional value in alcohol. I'm 100% okay with people restricting to zero their alcohol intake. And then looking at other excipients, preservatives, or dyes in foods, leaning more towards whole foods as opposed to foods that are processed when possible. I recognize that that is not easy to do in the American food supply, and it's a position of privilege to be able to afford foods that are organic and totally eliminated with these chemicals. Fermented foods, I'll point your eyes there, also can be a big trigger. So when we can start to avoid some of these things and replace them with other foods, if we call that a low histamine diet, I'm okay with that. But try to avoid the restriction that's going to drive the eating disorder. So in short, my recommendations, if you are thinking that this might be something that pertains to you, or you're a clinician listening to this and trying to figure out what to do with your patients, I think the very basic thing is just to screen every patient that walks in the door. If we are not looking for it, we're not going to find it. So every patient deserves to have this conversation with their clinical team, and we need to be screening and looking for it. The second is to, if you even think there might be like a whiff of mast cell activation syndrome in your patients, we can just treat them empirically. Go back and listen to last week's. There's many, many ways to treat this, but the very basic treatments are available over the counter. You do not need a doctor's prescription in order to start treatment. You can start with antihistamines. So if we think that there's something there, I just treat people. And if they get better, awesome. If nothing else, it at least helps point the patients in the right direction. And then my mission is number 3, which is to build these strong multidisciplinary teams who really understand eating disorders and mast cell disease. So we are all kind of listening in for those same cues and able to anticipate needs for patients. So there's a huge need for education in the eating disorder community. And then lastly, this is probably a reminder to me as well as other clinicians, is just to stay really curious and humble. I continue to be humbled by this subset of diseases. I always learn something literally every single day. And just when I think I've got things figured out, I learn something more. So this is a way for me to continue to grow as a clinician, and I've really, really enjoyed it. Some resources that I think would be super helpful. The Gaudiani Clinic has a blog on their website, which goes through in deeper detail patient cases and treatment modalities and other things. It's an excellent resource. Dr. Gaudiani is one of the leaders in the eating disorder world and mast cell activation overlap. And then there's a couple podcasts that I think are really interesting. The POTScast, which focuses on POTS, also has a series on mast cell disease, which is really great to listen to. And then Dr. Bluestein, who's an Ehlers-Danlos specialist, also talks a lot about mast cell disease. So those are some good resources for free that are out there. If you have any questions, please feel free to send me a note, sign up for the email list on my website. And if you're interested in scheduling an appointment, you can do on my website or scan the QR code here. Thanks so much for being with me today. I really appreciate your time, and I will see you next week.